Thank you very much indeed. It's really a unique pleasure to be here and in the presence of some of our favorite patients in the world, be inspired together, because I think it's not an exaggeration to say that the home team in Poland has contributed significantly to the progress we've made in multiple myeloma together with our patients. But I want to show you what we're doing now for relapse disease, and I really want to get you excited about the future, because I actually think that's better than what we've seen so far. So without further ado, you already heard beautifully from David Wiesel that we've had a number of new drugs. We have proteasome inhibitors here. We have immunomodulatory drugs. We have our first histone deacetylase inhibitor. In the laboratory, they work qualitatively different than conventional treatments. They've been in a variety of trials, and in the United States, we've had 11 new FDA approvals so far, and the prediction is we'll probably have 2 or 3 more this year with antibodies and maybe the oral ixazomib, we'll see. But I want to go over with you what, in fact, we have available and what I believe is really coming in the short and long term to manage this disease. So firstly, in the United States, we have this NCCN. It stands for National Comprehensive Cancer Center Network Guideline. But the reason I mention it, it actually looks at different drugs that are available by the weight of evidence that supports their use. So for example, Category 1 drugs here have randomized trials, big, large phase 3 randomized trials, as you know very well, supporting bortezomib, supporting lenalidomide, dexamethasone, now supporting panobinostat, and supporting pomalidomide, dexamethasone. So we have those available. And we have other drugs that are available, usually based on phase 2 clinical trials, but strong consensus. Quality of the data is very consistent. So let's go through what we already know, and then we'll talk about what I think are the new drugs. So the first thing is, all of you know, bortezomib was approved a long time ago, 2003, twice a week, intravenously for 2 weeks with a week off. But our good friend Antonio Palumbo taught us that if you give bortezomib once a week instead of twice a week, in so doing, you can cut down the incidence of neuropathy by about a half, and the incidence of serious neuropathy down to very low incidence in disease. So in the U.S., very often now, and I'm sure here too, bortezomib is often given weekly instead of twice a week. We learned that after it was approved. The other thing we learned was that bortezomib, when you give it subcutaneously at the same dose and schedule as you do IV, in the subcutaneous cohort of patients here, again, the overall incidence of neuropathy and the incidence of severe neuropathy, defined as grade 3, was very low. So we learned things about drugs that we've already been using for a long time, and we use now very commonly weekly subcutaneously bortezomib, and in so doing, it's very, very rare indeed that we have to drop or change a bortezomib dose or schedule because of neuropathy anymore. Now let's talk about what we do when we see relapse happens. Well, there is a role for those of us who are clinical caregivers. We still have a job. We need to evaluate, in fact, whether the patient has relapsed or not, whether it's a protein relapse but no other clinical sequelae. And in fact, although we in the past have always waited for features that you know of calcium or kidney or anemia or bone disease to treat relapse, I think it's important to know, particularly in the aggressive patients, that as soon as we see a protein that recurs or a protein trend that is persistently upward, since we have effective drugs nowadays, we intervene, not waiting for CRAB to happen, but actually to obviously prevent CRAB in many cases. The other thing that we do as we watch for relapse is think about these features that are on this slide. What is the age of the patient, the comorbidities, what are the other drugs that the patients had? David covered nicely the age, etc. But it suffices to say that we really do have a role with all of these drugs now available to us to think about what's the pace and biology of the patient's disease, and what is the host performance status. I think that Antonio Palumbo did a wonderful scaling system talking about the fit and the frail. We're going to have a scaling system like that for physicians pretty soon, the fit and the frail doctors as well. In any event, Pomalidomide is the second generation immunomodulatory drug you all know well. The data on which its approval was based is here. A phase 2 trial compared pomalidomide, low-dose dexamethasone versus pomalidomide alone. The combination worked about a third of the time. These responses lasted 8 months. It was pretty well tolerated, and based on this, our FDA gave it accelerated approval. Now, it's gone on, as you know. Dr. Demopoulos, and I suspect you were part of this trial, POM-DEX versus DEX. But in any event, this was an international trial of pomalidomide DEX versus dexamethasone. You all know it well. But I show it to you because it was a phase 3 trial, and it showed you that overall, even those patients which high risk defined as 17p deletion or 414 or standard risk, in all of those cases, it was in favor of the pomalidomide low-dose DEX here in terms of progression-free survival. Now, Dr. Demopoulos has extended this to the so-called STRATUS trial. Again, it's primarily a trial done in Europe in patients who are heavily pretreated. Now these patients are already exposed not only and refractory to lenalidomide bortezomib, but some of them to some of the new drugs as well. And many of them are double refractory, as shown here. And it confirmed the activity of this oral immunomodulatory drug, because if you look at all of the populations, whether it's the len refractory, bortezomib refractory, or both, the response rates are on the order of 35 to as much as 40%. Here's the progression-free and overall survival. So this is very active. It's a 2-drug combination, pomalidomide, dexamethasone. David showed you beautifully the data for the 3 drugs in the upfront setting, that is lenalidomide, dexamethasone, and you pick whatever proteasome inhibitor you want, but the 3-drug regimen. So what about the combinations in this relapse setting? So again, the Mayo Clinic, together with actually Dana-Farber, has been putting together pomalidomide, dexamethasone, and bortezomib. Martha Lacey in particular presented this at last year's American Society of Hematology, and just as you see up front, so it's true here in the relapse patients, that if you put pomalidomide dex together with bortezomib in this slide, you get very high response rates, even in high-risk myeloma, on the order of 80%, and progression-free survival that's significant here, as you can see. And this trend is also true if you take the new proteasome inhibitor, or the newer proteasome inhibitor called carfilzomib. So I'll just mention this. It's in the history and what we're doing with carfilzomib now. The history of this drug is it's an epoxy ketone proteasome inhibitor. It's not a boronic acid like bortezomib. It's irreversible chemically. So the depth of duration of the proteasome and the duration is longer. Suffice it to say, when it was given in mice and in men, it caused very little neuropathy, and in refractory patients, refractory to bortezomib and exposed to an IMiD, about a quarter of patients responded, and in the FDA's view, that warranted accelerated approval 3 summers ago in June. Now what happened after that was, in fact, further testing. So Keith Stewart from the Mayo Clinic and many colleagues from around the world carried out a trial where carfilzomib, or as you know it, this doesn't stand for Krakow, this actually stands for carfilzomib, but it's carfilzomib lenalidomide dex versus lenalidomide dex in patients with relapsed myeloma. I do want to mention, and it's kind of obvious, but I want to highlight it. If you do a trial of lenalidomide dexamethasone versus, in this case, carfilzomib len-dex, these patients have to be not exposed to lenalidomide or sensitive still if they're going to be randomized. And the reason I point that out is, if you just look here, the number of patients that were exposed to lenalidomide is really a very small number, and they were not refractory. So this is an earlier population of patients than some of the other relapse trials. Nonetheless, in the New England Journal of Medicine was published this trial because if you look at the Kyprolis, Rev-Dex versus Revlimid dexamethasone groups, you know this well, that the median progression-free survival, whether you had standard risk myeloma or high-risk myeloma, was in favor of the 3-drug combination. So this supports using 3 drugs in the relapse setting, just as you heard has been done in the upfront setting, incorporating immunomodulatory drugs with proteasome inhibitors. The secondary endpoints in that study were, in fact, the overall and extent of response, and the yellow bars here are the 3-drug regimen, in each case statistically significantly increased versus Lendex, as shown here. And finally, one of the benefits of this particular proteasome inhibitor is that in spite of our early concerns that there were cardiac toxicities, and I do think there are some real cardiac toxicities, in this large randomized trial, there was no real significant difference between lenalidomide, dexamethasone, and Kyprolis Lendex in terms of a variety of features here in terms of adverse events of all kinds. So suffice it to say, the advantage of this that I was going to mention, and I guess I've taken it out, is that in fact the incidence of neuropathy was far lower when you use Kyprolis Lendex than what we've seen in the past with at least intravenous bortezomib. Now, if in fact pomalidomide dexamethasone has been combined with bortezomib, and I showed you it's quite active with about 80% response, what about carfilzomib or Kyprolis with pomalidomide dexamethasone? And that's shown here. Dr. Shah from MD Anderson at Texas has combined in far advanced patients carfilzomib, pomalidomide, low-dose dex. Overall benefit rate was over 80%, and patients are having prolonged progression-free and overall survival. So I think we're going to a trend of 3-drug combinations even in the relapsed population. So now we have these 2 proteasome inhibitors. There has been, and maybe again this trial was primarily in Europe, a trial comparing carfilzomib at a much higher dose, 56 milligram per meter squared, and dexamethasone versus bortezomib dexamethasone, the so-called Endeavor trial, as you know here. This I show you because in this particular experience, the Kyprolis was in fact superior here to bortezomib in a statistically significant way in terms of progression-free survival. This benefit actually extended to a variety of subgroups as shown here, including the risk groups of standard risk and high-risk patients defined as 414 or 17p deletion. They had a benefit in terms of carfilzomib. And then if you look at the pattern of drug refractoriness, that's also true here. This is a whole variety of categories, whether patients had lenalidomide, bortezomib, or both. And you can see here that the benefit was high. And here's the slide I was going to show you about neuropathy right here, that in fact there was a much lower incidence of neuropathy with the carfilzomib than there was with the bortezomib in this large phase 3 randomized trial. So we have, if you will, a new IMiD, pomalidomide dexamethasone. We have new proteasome inhibitor, carfilzomib. We're just learning how to use it in terms of the dose and schedule, but we obviously have seen a synergy when you put together IMiDs and proteasome inhibitors in the initial treatment of myeloma and also in relapse. Now, we also, for the first time this year, have a histone deacetylase inhibitor FDA approved in myeloma. Why was it used? Well, this is one of my favorite cartoons. We were talking with the rector earlier about protein degradation. And all of us in this room are excited because we've used proteasome inhibitors to block the breakdown of protein in the proteasome. But if you use histone deacetylase inhibitors, you can block the breakdown of protein in an alternative mechanism called the agrisome. And you can use broad-acting HDAC inhibitors such as vorinostat and panobinostat, and we've been involved in making more selective HDAC6 inhibitors, and I'll show you in a minute. The HDAC6 binds the protein, binds to this microtubule complex, and brings the protein to the agrosome for its degradation. So the first trial was in fact a trial of vorinostat, HDAC inhibitor, to block the agrosome with bortezomib to block the proteasome. It was a very large trial, statistically significantly better response rate when you use the two drugs to block both pathways. The problem was that the progression-free survival advantage was only about 1 month, from 6.8 to 7.6, even less than 1 month. And in myeloma, we are spoiled or whatever. We're lucky and grateful that we have been able to have very big benefits in terms of progression-free survival. And the reason this wasn't longer is there was too much in the way of diarrhea, fatigue, and thrombocytopenia. Now, the next HDAC inhibitor that came along is panabinostat. It was used for the very same reasons that I just mentioned to you. And, in fact, it was a positive trial. There were higher response rates when you used panabinostat to block the agrosome with bortezomib to block the proteasome. And the progression-free survival was 4 months benefit. So that was good, but I want to point out there were still too many side effects. This was only given once a day, every other day for 2 weeks out of a 3-week cycle, so only 6 doses a month. And in fact, if you look at it carefully, about 1/3 of the patients had to discontinue therapy here because of adverse effects. Nonetheless, the FDA has approved it, and we do have this drug available for use in our country. Now, we actually, in our laboratory, and I'm not going to show you any of the data, but have been involved in making an HDAC6 selective inhibitor. In fact, it's called ricolinostat. In dose escalation studies, the very first in man, we were able to show a response rate of about 50%, and 30% of patients whose myeloma was refractory to bortezomib responded. This was a liquid formulation. We now have an oral formulation, but it can be given daily for 21, 28 days, etc. It's very well tolerated. And just to show you in the early experience, when you combine this drug with lenalidomide dexamethasone, you can see here in far advanced myeloma, you get quite a nice response. I think you all know this is a waterfall plot, and this is the protein in myeloma going totally away in some of these patients. But suffice it to say, the HDAC inhibitors, I think, still have a very strong case in our disease for blocking protein degradation. And I won't show you today, but the selective HDAC inhibitors block IRF4 and c-MYC, which is very important in myeloma biology. So stay tuned for a more tolerated agent. Now, I think I'm here today because I'm supposed to tell you something new. So I want to show you why I am so excited about the future. And I'm going to do it in 4 ways, quickly but hopefully clearly, okay? Immune therapies, some of us have been wanting immune therapies in myeloma for 3 or 4 decades. I think it's finally happening, and I'll share my excitement. I'll mention to you a couple of other ideas of how we can target protein degradation again, a couple of thoughts about completely new targets, and my assessment of what we're doing with genomics in myeloma to understand the disease better, but to understand what are the Achilles heels that we can target in myeloma and really make a difference, not an incremental difference, but a real difference. So very quickly, I want to show you. David mentioned this in his nice talk, but we're finally going to get some monoclonal antibodies in multiple myeloma this year. That's a promise, okay? And the antibodies that we're going to get are called elotuzumab, which targets something CS1 or SLAMF7, and the CD38 antibodies, daratumumab, or now this is SAR antibody against CD38. We're excited about it because the elotuzumab monoclonal antibody, which as a single agent only achieved stable disease, was combined with lenalidomide dexamethasone. Dr. Tai in my laboratory showed that if you add antibodies to IMiDs many years ago, you augment ADCC. It went to the clinic, and this particular randomized phase 3 trial was just published, where if you give lenalidomide dexamethasone and elotuzumab, you have a superior, statistically significant prolongation in progression-free survival versus lenalidomide dexamethasone alone. And this advantage, again, is across all of the subgroups. You don't need to look at all of this, but this includes high-risk disease as well. And this is one of the most exciting points. It doesn't probably matter if you have 17p deletion or high-risk disease, because the mechanism of killing here is an immune mechanism. It doesn't matter if, in fact, the genetic component is quite aberrant in the cell. That remains to be proven, but that's one of the exciting parts. Here's the secondary endpoint, that in fact, if you look at the response rate here, it was higher when you added a monoclonal antibody. And in fact, that particular study and other supporting studies, in my opinion, will result in the approval or registration of elotuzumab, lenalidomide, dexamethasone for relapse disease either later this year or early in 2016 at the latest. Now, what about the CD38 antibodies? I'm going to take a minute and just talk about this. I would let you know that in 1983, I was part of an antibody called T10, T-cell antigen 10, which we described on activated T cells now 30 years over, or 32 years ago, I guess. And we have a paper in 1984 that showed that this antigen was on multiple myeloma cells. And we didn't do anything about it because this antigen is on activated all kinds of effector cells. It's on endothelial cells. It's on half of the hematopoietic progenitor cells. And as is true very commonly for me, I was in particular very wrong, because I thought you couldn't target this antigen and have a favorable therapeutic index, being very honest. But you'll see that that was fortunately incorrect. And this paper that just came out from the Netherlands and from Paul Richardson in our group in New England Journal shows that as a single agent in a phase 1 clinical trial, first time in man, dose and schedule finding trial, that the response rate here was 36%, about a third of the patients, and it was 15 patients. It's a very small trial. But there were some complete responders and some, the term very good partial responders to the single agent CD38 monoclonal antibody. So very, very exciting indeed, and it was well tolerated. Sagar Laniel at Emory did a phase 2 trial, and I don't know if you all might have participated in that one, but it confirmed about a 30% response rate. Now we know the dose to be 16 milligram per kilogram. That was defined in the phase 1 trial. And we know that the durability of some of these responses can be quite impressive. This is from the phase 2 trial that was presented at ASCO. But you can see some of these are VGPRs, et cetera, and they can be quite durable. Now, as I mentioned to you, with the elotuzumab story, if you add lenalidomide, you augment the antibody-dependent cellular cytotoxicity. So the same thing is true here. If you add lenalidomide to daratumumab, you can see here this waterfall plot. You get a very significant number of patients who completely clear their monoclonal protein in relapse disease. So antibodies are important to target the tumor, but the ability to add other things to augment the immune response is really going to be what makes the difference. There's another 38 antibody called SAR from Sanofi Aventis. I'll just mention it. Just like daratumumab in the relapse setting, when you add lenalidomide dex, about 2/3 of patients respond. But I wanted to mention this because I wanted to highlight this particular slide. If you look over here, even though the numbers are small, this antibody together with lenalidomide and dexamethasone worked in bortezomib refractory, lenalidomide refractory, carfilzomib refractory, carfilzomib and pomalidomide refractory disease. In other words, this concept that the immune therapies are going to offer all of us who are myeloma caregivers in this room an opportunity to have an effective therapy where we haven't had one before, I believe is very real. So it's elotuzumab targeting SLAMF7, and it's in fact the 2 CD38 antibodies, daratumumab and SAR. Now there is an immunotoxin from Germany, which you probably know about, from the Biotest company. where they have actually used an antibody against CD138, which targets syndicam on myeloma, and they've linked it to a maytansinoid immunotoxin, so the antibody binds to the cell, the immunotoxin is internalized, and in fact, once it's degraded, there's an inhibition of cellular division here. And I mention it to you because we've been involved in helping these investigators at BioTest. It's quite active, but it's really active if you combine it with lenalidomide and dexamethasone again. How active is it? It's an 83% response rate, even in patients whose myeloma is refractory to lenalidomide and bortezomib, at least in some cases. So antibodies and immunotoxins are coming. Now, I'm excited about the immune response because we have now the ability to take the brakes off of the patient's own immune system and allow that system to recognize their tumor. You know this very well. PD-1 is expressed on effector cells in the patient, like CD8, natural killer T cells and natural killer cells. And its ligand, called PD-L1, is expressed on myeloma. It's also expressed on these other double agent cells here, plasmacytoid dendritic cells and myeloid-derived suppressor cells that augment myeloma cell growth and drug resistance. So if you block with an antibody to PD-1, PD-L1, you allow the T cells and NK cells to do their anti-immune activity, and you block the help that's coming from these plasmacytoid dendritic cells and myeloid-derived suppressor cells, and you let the immune system target myeloma. It's almost as though Poland would beat Germany in soccer, right? That didn't happen last night, I don't think. But it's coming. It's coming. I've heard it from good sources. In any event, there are ongoing clinical trials now of using these checkpoint inhibitors. This is a summary slide, and I'll just have you focus on the bottom here. In myeloma, we mentioned antibodies. I'm not going to mention vaccines here today, but you can use, and we are, and others are testing them. The immunomodulatory drugs upregulate the immune response, and you can add them to either cellular therapies or checkpoint blockade, and you can get a significant immune response in patients against their own myeloma. I did put in just a couple of slides to show you why I'm so excited. Lenalidomide augments antibody activity. Lenalidomide, recently published by Gulu from our group, downregulates the expression of PD-L1 on myeloma cells. It downregulates it on these other cells that help myeloma grow, and it downregulates PD-1 on T cells. In other words, if you add checkpoint inhibitors to lenalidomide, they are more effective. What's the evidence for that? Here's an experiment that I'll show you from patients. They're CD4, CD8, natural killer cells, the NKT cells, or these monocytic cells. Control, checkpoint blockade only, lenalidomide is the pink, but the green bar in each case shows you if you add lenalidomide to checkpoint inhibitor, you get more intracellular interferon gamma. That's more activity, immune cytolytic activity by all of these subsets when you combine the immunomodulatory drug with the checkpoint inhibitors. And you know, here's the evidence. Does that kill myeloma cells or not? The height of these bars shows you killing myeloma. This is with checkpoint inhibitors alone. This is lenalidomide alone. And this is lenalidomide and the checkpoint inhibitors. So I think you may be part of some of these trials here. I know Jesus San Miguel is working with us and other centers, but the checkpoint inhibitors plus immunomodulatory drugs are being very active in multiple myeloma as we speak. And this is some of the preclinical data that supports that view. And finally, in terms of immune therapies, what about the CAR T cells? You've heard a lot about those in leukemia, CLL, ALL. We have also in myeloma multiple targets for the CAR T cells. You know what this means is you actually ex vivo take T cells from patients, you transfect in so that they're on the one hand activated and also selected for a particular target. You expand them and then you transfuse them back to patients. In myeloma, there's not very much data, but I want to share with you why I'm so excited. This is one of my favorite patients of all time, a 50-year-old woman who had very relapsed refractory myeloma a little over a year ago. Refractory to what? To carfilzomib, pomalidomide, verinostat, elotuzumab, honestly given all at the same time. She was clearly destined to die. She went to my friends in Philadelphia, and she actually got a second transplant, or a third transplant, to be honest, for cytoreduction. And then she had transfusion of her CD19 CAR T cells. And I'm very happy to tell you, at about a year and a half now, she remains in a molecular complete response with the persistence of these T cells. But why? She's getting every other day lenalidomide, which we are just doing empirically, but this is now having survival of these myeloma-selected autologous T cells. So there's a lot of work to be done. I don't want to overstate it, but I honestly think immune therapies are coming to myeloma. To quickly then move on, what about protein degradation? We now inhibit the proteasome together with bortezomib and with carfilzomib. We are now blocking what upstream of the proteasome, the deubiquitinating agents up here in clinical trials, and we have some new proteasome inhibitors. I'll just show you quickly that. One slide to show you that upstream of the proteasome is the deubiquitinating agent. If you block the deubiquitinating agent, it's like you're blocking the proteasome, but it's upstream, so the purpose of this is to overcome proteasome inhibitor resistance. In Memorial Sloan Kettering, and now at our center too, we have a clinical trial of the first DUB inhibitor. It's right here. It blocks the breakdown of massive accumulation of myeloma ubiquitinated protein here. Here's Velcade blocking the proteasome. This doesn't block the proteasome. It blocks the protein, sure enough, but it's upstream, and in the preclinical models, it can overcome proteasome inhibitor resistance, so we will see. Now, the other thing to mention to you quickly for the proteasome inhibitor is this. We have an oral proteasome inhibitor. David mentioned this. It's called the son of bortezomib, or ixazomib. It's oral. It's only given once a week. It's extremely well tolerated. In our experience, not very much neuropathy. As a single agent, it is about 1 in 5 patients have a response and additional patients benefit. Shaji Kumar from the Mayo Clinic published this in Blood. And as David so nicely shown you, and I want to highlight it here, if you give it with lenalidomide dexamethasone as initial treatment, an all-oral regimen, and then you give single agent ixazomib as a maintenance, you can increase the response here. I've had patients on it for over 5 years as a single agent, as maintenance. It's extremely well tolerated. But won't it be nice to have an all-oral regimen, proteasome inhibitor, immunomodulatory drug, and steroids for our patients in the near future? And the final point about the proteasome inhibitors is this one. You'll hear about this at the international workshop, but we have another proteasome inhibitor. It's a broad proteasome inhibitor. All the other proteasome inhibitors block the chymotryptic site, but this one blocks the chymotryptic, tryptic, and caspase sites. And it's being tested and going on to be registered in combination with pomalidomide based on this data. They're synergistic in killing patient myeloma cells. Low doses of both drugs, here's low doses combined, are very active in the preclinical models. And you'll see, those of you who are going to the International Myeloma Workshop, that the data is very strong for combining this with pomalidomide. And my final points are these. I'm not going to talk about these agents today because they're earlier, in my opinion, in testing. There's a tablet HDAC6 inhibitor. BTK inhibitors are very active in CLL and Waldenstrom's, as you'll hear about in a minute from Jorge. But in myeloma, I think they don't quite make the first team. I think the KSP inhibitors are strong. We'll see how well they do. They're being tested together with proteasome inhibitors, AKT inhibitors with proteasome inhibitors. There are the nuclear transport inhibitors that are being tested. all of these are exciting, the different CDK inhibitors. We can't talk about everything today, but I think suffice it to say there are more opportunities. What I want to finish with is 3 quick slides about genomics. Myeloma is very complicated. When we did our myeloma analyses of whole genome sequences, we found 55 to 60 mutations at the time of diagnosis in all of our patients. That's problem number 1. Problem number 2 is that there's 3 to 5 clones present right from the start. So we have a very heterogeneous, complex problem. Here's a clone right here in a patient at the time of diagnosis, and when the myeloma relapses, there's a new subclone that wasn't there before, as you can see here. Here's a myeloma at the time of diagnosis that had 2 subclones, and when relapse happened, one of the subclones was predominant and one of them less so. And here's at the time of diagnosis, this particular subclone goes away, but a new subclone comes. The point I want to make is that we need to take the most active drugs we have. Maybe it's a proteasome inhibitor and an IMiD. Someday an antibody may be added, maybe an HDAC inhibitor. I don't know. But we're going to add them together based on science, and we need to do it very early, in my opinion, because if you let this evolution occur, I honestly do not believe myeloma will be curable at that stage. So I think we're blessed because we have active drugs and we can use them earlier. Now, 2 other things, and this is the end, but I think it might be the most exciting part. Why do proteasome inhibitors work in myeloma? We were talking about this at dinner a little bit. Proteasome inhibitors, and with the rector too. Proteasome inhibitors work because myeloma cells make too much protein. And if you block the ability of a myeloma cell to deal with its own protein, that's an Achilles heel. I make that Achilles heel means the heel is H-E-A-L, not H-E-D-L, okay? Because we're going to use this against the myeloma. So I have 2 stories to share with you that I'm very excited about. In our genomic data in myeloma, lymphoma, and leukemia, we found underexpression of a certain gene called YAP1 in a subset of patients. So why might I want to talk to you about that today? Well, it turns out myeloma cells have lots of ongoing DNA damage right from the start, and the reason they don't die is that their pathway, they mobilize because of all this genomic instability and DNA damage. They have DNA damage response genes activated. They have this nuclear-able, and what's supposed to happen is YAP1 here is part of a death pathway, P73-mediated death, which occurs even when P53 is deleted. The problem in this subset of myeloma patients is YAP1 is not present. And Francesca Cottini in our laboratory put YAP1 back into myeloma cells in the laboratory and in animals and showed, in fact, that she could, in fact, move patients from not having YAP1. If they had YAP1, this pathway, this natural endogenous death pathway occurred. Now, why am I showing you this slide? Because in patients with myeloma, the reason this YAP1 is not expressed is a kinase, STK4. If you knock out this kinase, YAP1 comes on and these cells die. And we have, in fact, now STK4 kinase inhibitors and nanomolar. We're making great progress, to be honest with you, and it might be someday that in this subset of patients that lack the ability to have this endogenous death pathway, it would be an Achilles heel if we could turn this pathway back on and, in fact, restore endogenous apoptosis. So I think that's really exciting. And the other story that's just recently come out of this is in our genomic analysis, we looked at patients who had really high levels of c-Myc, and they really don't do very well versus those who have lower levels. And what is this subset of patients with high MYC levels? Well, MYC actually causes 2 problems for myeloma cells. It increases the replicative stress. These cells have so much replication and DNA damage that they activate DNA damage response genes, and they have a lot of oxidative stress. So let's do 2 things to this evil myeloma cell. Let's make it impossible for them to deal with this replicative stress. And in fact, there are drugs now, ATR inhibitors, where you can actually block replicative stress. And over here, there are drugs to turn up the oxidative stress. In other words, in the setting of all of this stress, we block the stress response, we increase the stress over here, and we get a prolonged and a profound induction of apoptosis. And those drugs are now available, and I think that is moving rapidly towards the clinic. But the point I'm trying to make is biology, bench to bedside, figure out, in this instance from the genomics, not a mutation to target, but what's the biology, like the proteasome, that we can target. The first case, a kinase STK4, and this one, the stress response, and turn myeloma against itself. So very quickly, what I've tried to do is tell you a little bit about how we manage myeloma now in the refractory setting, the novel agents, oral proteasome inhibitors, antibodies, the HDAC inhibitors and others, not alone, but combined with lenalidomide, dexamethasone. And in my opinion, what you're going to see in the future, I mentioned the highlight, in my opinion, of taking the combination immune approaches to augment endogenous tumor-selective immunity. But maybe someday we're going to see combinations of targeted therapies with immune therapies. And I do think, used early, we have an unprecedented opportunity to change the natural history of this disease. So closing, I want to again thank very much my hosts. It's an extraordinary privilege to be here with my colleagues, and I do cherish the personal and professional friendships that we share. Thank you.